Good morning. I'm Dr. Sanmuga Piriya. Today's topic for discussion is electroconvulsive therapy. Okay. What is electroconvulsive therapy? Any idea? So, electroconvulsive therapy is nothing but ECT. Most of the psychiatric people who will be on long-term drugs, they will be keep on taking drugs. Once their symptoms is not revert back, they should go for second line of treatment. Next is they will be giving electrical shock to produce the artificial seizure activity. Okay, so that is electroconvulsive therapy. So most of the people thinks that life inside the mental ill hospital is very horror and scary. Okay, so for that they will think, oh, something will happen. This effect is mainly shown in the medias, like they will be giving some electrical shock, 4 or 5 people will be holding their legs and one nurse will be giving some current, then the patient will sleep, and they will be telling and they will be crying, so many things. So we had that expectation like that, but it is not so. So it is a smooth procedure and it is a safe procedure, so that for betterment of the patient's life, quality of life. So for that, we are giving the electroconvulsive therapy. Okay. So moving on to the history. The main history here is in the year 1930, one young scientist by the name Meduna, she noticed most of the schizophrenia patient who had the symptoms, okay, they are temporarily disappear after a normal seizure. If a patient develops a seizure, following the seizure, their schizophrenic symptoms has been reduced. Okay, so for that she made on study and she found out that, okay, why can't we can artificially induce a seizure? Then we can treat the patient. Okay, so she artificially induced the seizure by injecting the camphor oil in a patient with chronic catatonic patient. Okay, so she has injected and she has made the artificial seizure to form. Then what happened? Then the patient has recovered halfway. Okay, so she repeatedly gave. Then finally found out the some effectiveness. Okay, in the artificially given illicit seizure, some improvement in the psychological illness. Okay, then after that, following the intervention of methotrexate, we made the ECT as a safer treatment for all the indicated psychiatric patient. Okay, then this is also used as a second line therapy, those who are resistant to the pharmacotherapy. Then in few conditions where we are using this as a first line of treatment also. Okay, so moving on to the proper definition. The definition per se says that nothing but it is an ECT is nothing but artificially induction of grand mal seizure through the applications of electrical current to the brain. Here the stimulus we are giving is nothing but the current. We are artificially giving the current to the brain and producing the seizure to the patient. Following the seizure, there is some improvement in the psychological behavior in that schizophrenic patient. Okay, so we are placing the electrode. Usually we are using single electrode technique or two electrode technique. That in single electrode, if we are plan to use a single electrode technique, that is unilateral, means we are keeping it in the non-dominant side of the brain. If we are using two electrode, that is we are placing it bilaterally in the frontotemporal region to give current to the patient. Moving on to the theories. The main mechanism behind this, it has lot of theories. Okay, the main these are the following theories involved in the electroconvulsive therapy. First is the neurophysiological, that is neurotransmitter theory, neuroendocrine theory, anti-convulsion theory, brain damage theory, and psychological theory. and anti-convulsant, then cerebral blood flow and their metabolic changes, and they will have the increase in EEG, like EEG activities, and they have delirium and sleep theory. So many theories are there. Then we will see the neuroendocrine theory. Here the seizure causes the hypothalamus to release certain chemicals such as prolactin, neuropeptide, and melatonin. These chemicals that causes some changes throughout the body. This seizure may causes the release of neuropeptide that regulates the mood. Okay. So by inducing this release of chemicals, there is some change throughout the body. That is nothing but some alteration in the psychological behavior, like because of the prolactin release and neuropeptides and melatonin release. Then moving on to the neurotransmitters. Neurotransmitters, ECT mainly works like an antidepressant medication. By changing the electrical receptors, which are important to mood-related chemicals. So what are all the neurochemicals? What they will do now? It mainly stimulates the beta cell receptors, monoamine release, and modulation of serotonin. Then anti-convulsion therapy. What is the anti-convulsion therapy which is used? Is nothing but the ECT, which induces the seizure technique. It teaches the brain to resist the seizure. This affects to inhibit the seizure, dampens and abnormal activities of the brain circuit and establishing the mood activities. Okay. So then comes the brain damage theory. What is brain damage theory? The brain damage theory is nothing but some shock when you are giving to the brain. It causes the damage to the brain and causes a transient loss, memory loss and disorientation that creates an illusion that the problem is gone and patient will be euphoric, which is frequently observed as a result of brain injury. They both are temporary only, but if you are frequently doing this, then the brain will automatically change and patient will go into a normal, better physiological life. Okay. So in the brain damage theory, nothing but the shock usually damages the brain, okay, which causes the memory loss and disorientation. That creates an illusion, and that problems are which are gone. And the patient usually thinks, usually that illusion is nothing but the problem is gone and patient is euphoric, which are frequently observed as a result of brain damage, brain injury. They are usually temporary only, okay. Then the main psychological theory. Psychological theory is depressed patient is often feels guilty and the ECT satisfied the need of the punishment. Alternatively, the dramatic nature of ECT and the nursing care afterwards makes the patient feels that they are being temporarily seriously it's a placebo effect. Okay, so it is not considered as a full drug. Okay, it's a placebo effect. Nothing but a psychologically, we are just psychologically changing the patient activity and the nursing care towards them. Okay, then moving on to the indications. What are all the indications for giving the ECT? The main indication is the patient who are having severe endogenous depression. Severe endogenous depression who are not responding to the medical treatment, and the patient who are associated with the suicidal tendency. So severe depression that leads the patient to the suicidal tendency. So they are the most important patient to go for the treatment of electroconvulsive therapy. Okay. So the most important thing is severe endogenous depression who are not responding to medical treatment and who are associated with the suicidal tendency, and the patient with catatonia and mania, and patient who are with bipolar mood disorder and schizophrenia, patient who are having previous history of good response to the ECT, and already patient had accidentally who had undergone some ECT, and again there is some revert back after 1 or 2 years. If the patient again developed some psychiatric illness, means we can try them on ECT. Already once they had a good response, they will have the good response to the ECT. Okay, so main indications are severe endogenous depression who are not responding to medical treatment and associated with suicidal tendency, patient who are having these symptoms, and catatonia mania, and patient with bipolar mood disorder, and patient with who is having schizophrenia, and patient who are having previous history of good response to the ECG. So we have seen the indications. Now we are, excuse me, we are going to see the contraindications. Contraindications is classified, they are broadly classified as absolute contraindication and relative contraindication. Absolute contraindication is nothing but the patient who had the recent myocardial infarction in the last 3 months, who had the MI in the last 3 months, then patient who had the cerebrovascular accident in the last 3 months. Okay, if this patient who are already had an MI or cerebrovascular accident, if we are making this patient to go for ECG, what will happen? The patient will have the consequence. What now if it is nothing but we are artificially inducing the seizure? So because of the seizure, there will be a sympathetic stimuli. If sympathetic stimuli increases, what will happen? There will be increase in heart rate or what? Increase in BP. So if there is increase in heart rate and increase in BP, the patient will have further worsening of the myocardial infarction. Then not only the increase in heart rate and increase in BP, they will have increase in intraocular pressure, intracranial pressure. Suppose if an intracranial pressure increases, what will happen if an already patient who had a cerebrovascular accident, if again the intracranial pressure increases, what will happen? Patient again will develop CVA. Okay, so we should not take them if they had only less than 3 months. Once 3 months has gone, their acute phase has been healed and some modification would have occurred. Okay, then if already who had a raised intracranial pressure or patient who had a severe chromocytoma. Chromocytoma is nothing but their adrenaline defect. So because of that, they have a severe, that is malignant hypertension they will have. Because of that malignant hypertension, and in that patient, if you are giving artificially increasing the BP, what will happen? Patient again they will have seizures and rupture of vessels. So again MI will happen. So these are all the absolute contraindications. Those who are had a recent MI, who had less than 3 months, or cerebrovascular accident who are less than 3 months, and rise in intracranial pressure and pheochromocytoma. Then moving on to the relative contraindication. Relative contraindications, who had a recent intracranial surgery. For any RTA, if patient has undergone subdural or extradural hemorrhage, they will be going for intracranial surgery. If those patient, if they happen to have an surgery again, what will happen? Here, main thing, we are producing an electrical current to the brain, and following that current, patient is having seizure activity. Okay, so because of that seizure activity and some recent surgery, there will be further insult to the intracranium. So we should have 3 months, 3 to 6 months rest period. Then only we can take them for ECG. Similarly, for intracranial space occupying lesion, already there, if there is any space occupying lesion in the cranium, they will have a minimal increase in ICP, intracranial pressure. If we are giving eliciting and seizure, means in that intracranial pressure increased to patient, if further we are increasing that, then patient will go for major cerebrovascular accident, and they will go for paralysis, some compressive symptoms. Okay, so better we should make them treat the cause, underlying cause for increase. That mass lesion we have to remove. Okay, recent intracranial surgeries and intracranial mass occupying lesion, okay, space occupying lesion we should treat. Then only we can take the patient for ECG. And few patients who had cerebral aneurysm not on treatment or not on regular treatment, means This patient is having aneurysm. If this patient, if you are increasing the sympathetic activity, then this aneurysm is likely to rupture, and following that, patient will have seizures. So treat the aneurysm either radiologically or by surgical. Okay. Then only we can take the patient for ECG. Similarly, not only the cranium, and few patients have some ocular defects like retinal detachment or glaucoma. Glaucoma is nothing but the increase in intraocular pressure. Okay, due to the obstruction to the angles, so that the anterior chamber and posterior chamber pressure got raised. So because of that increase in intraocular pressure, patient will have severe headache. If in spite of that, if we are taking this patient, if we are giving artificially eliciting the seizure, means still further increase in intraocular pressure, then the patient will go for sudden painful vision loss in glaucoma will occur if there is some sudden increase in intraocular pressure. Or already patient had retinal detachment. If we are happen to increase the intraocular pressure, then further worsening the condition will occur. So better avoid the patient or treat the patient. Then you can take them for ECT. Until then, you can treat them with medical management. Okay. Then moving on to the cochlear implants. Then, so if already had patient had some cochlear implant, if we are having the current, giving the current for electrical stimuli, then their program will get altered. So better not to use in cochlear implantation, or before that we have to remove, then only. Okay. Then moving on to the cardiac problems. If already patient has some conduction abnormality or aortic aneurysm or any uncontrolled angina, if these patients are happen to go for ECT, they will have initially, we will see it in subsequent slides, what are all the physiological changes will occur in during an ECT. Main cardiac thing is patient initially will have the parasympathetic activity. Once the parasympathetic activity is occurred, now patient may go for bradycardia, hypotension. That is also is bad to this patient. And few conditions there will be sustained increase in sympathetic activity. If there is sustained increase in sympathetic activity for an uncontrolled angina, what will happen? Patient will have increase in heart rate, increase in BP. In an angina patient, if you are having an BP of 190, 110, a heart rate of 120, what will happen? Patient will again go for an MI due to mismatch in oxygen demand versus oxygen blood. Okay, demand versus supply mismatch. So for that further defect in angina. Okay, then if already patient is having aneurysm, if again patient develop this, what will happen? Patient will, the aneurysm will rupture and go for acute abdomen shock and patient will die. So better treat the underlying pathology, then go for ECT. Okay. Otherwise, we can postpone it by taking them, by giving them on medication. Then once the aneurysm or angina get controlled, then by medical management or any surgical management, then we can go for the treatment per se with ECT. Okay. Then if the patient is having major bone fracture, long bone fracture, we should not go take them for for ECT. Or in patient with severe osteoporosis or severe vitamin deficiency, vitamin D deficiency, they will have brittle bones. In this seizure, they will have tonic and clonic contracture. So because of that, patient will develop some bone fracture or dislocation. Okay, so they will have mostly because of this already patient will be on lithium drug. That is also calcium defect will happen. So we should be very careful while handling them for ECT to this kind of people. Okay. Then if patient on deep vein thrombosis, not on anticoagulant, then If you happen to give ECT, then the thrombus will get dislodged. So better do an coagulation profile. If the coagulation is normal and the thrombus is not is under control, okay, by antihypertensives, sorry, anticoagulants. What are the anticoagulants? You know, heparin, yes, injection heparin or tablet aspirin or aspirin with clopidogrel, then warfarin, acetron, dabigatran, so many things, so many recent anticoagulants therapy are there. Okay, by giving these drugs, we have to control the thrombus. Then we can go for ECG. Otherwise, if patient had deep vein thrombosis, not on any anticoagulation, if you are giving them, patient will have taking them for ECG because of the physiological changes. The thrombus will likely to dislodge and go and block the intracranial vessels or pulmonary vessels. If pulmonary vessels gone, then pulmonary edema. If it gone to the cranium, it will go to CVA. If it gone to the heart, patient will go for MI. So treat the condition with anticoagulant. For a deep vein thrombosis patient, then you can take the patient. Okay. Then high risk pregnancy. Who had a high risk pregnancy? Who is noted for miscarriage, or patient who had severe pulmonary PAH, pregnancy induced hypertension, in whom already they will have increase in blood pressure. So if these kind of patient they are taking to ECG, patient will likely to go for severe increase in sympathetic activity and they will develop seizure. Okay, eclampsia, pre-eclampsia, so many things can happen. So better avoid it in high risk patients. Once after delivery, then you can take them for ECG. Till that time, continue them on oral medications. Okay. Then moving on to the physics behind the ECG. What is the main physics? As I have mentioned earlier, we are supplying the current transcutaneously. Okay, not by percutaneous. Okay, it is transcutaneously. We are supplying the electrical current. Here we are placing two electrodes which are positioned unilateral or bilateral. If you are placing the electrodes unilaterally, what you have to do? The electrode should be kept in non-dominant site, non-dominant brain. Two electrodes should be placed in unilateral brain, or bilaterally if you are placing the two electrodes, it should be kept in frontotemporal region. Okay, frontotemporal region we have to place two electrodes in bilaterally. Unilaterally means non-dominant brain, or bilateral means frontotemporal region. Okay, then moving on to the phases of ECG. Okay, what are all the main thing we are going to note? It is generalized after applying the current. By placing the electrodes, we have to apply the current. Okay, then after applying the current, we will see the generalized tonic-clonic seizures. Okay, GTCS. In that GTCS, it has so many phases are there. It has mainly three phases: latent phase, tonic phase, and clonic phase. In latent phase, what is the latent phase? It observes for 2 to 3 seconds. In tonic phase, it observes for 10 to 12 seconds. Whereas clonic phase, it lasts for 30 to 50 seconds. Okay. So once we are achieved this phase, then the seizure will be noted. The seizure usually noted for more than 25 seconds, but it should last for 120 seconds, not more than 120 seconds. The optimal seizure duration should be more than 25, but it should be less than 120 seconds. Then how much current we are doing? What is the duration? So what are all the typical settings in the ECG machine we have to keep? The pulse should be 60 Hertz and the duration should be 0.75 milliseconds and the total stimuli duration should be 1.25 seconds. Okay, so like this we have to keep the current. So once we have given the current by after placing the electrode, then we have kept the settings: pulse of 60 hertz and duration of 0.75 seconds milliseconds and the stimulus of 1.25 seconds. After doing this, then what we have to do? Then we have to place the electrodes. Then we have to give the current. Unilateral or bilaterally, we have to place the electrodes. Okay. Then we have to produce the current. Then we should observe for generalized tonic-clonic seizure with 3 phases: latent phase, tonic phase, and clonic phase. Then the seizure duration should be 25 seconds. It should be more than 25 seconds, but it should be less than 120 seconds. Okay. Suppose if the seizure lasts for more than 150 to 180 seconds, mean what you have to do? You should not last up to those seconds, okay, because it will cause the drastic damage to the patient brain and other general physical condition. So you should terminate the seizure. If it lasts for 150 to 180, if it lasts for more than 150 seconds, how we can terminate? By giving diazepam. We can give diazepam 5 milligram IV so that we can stop the seizures. Or sometimes if it is not responding, then we can give thiopentone 7 milligram per kg body weight we can give. Or if still it is not subsiding, then you can put the thio as infusion, thiopentone as infusion, or phenytoin we can give. Okay, so these are all the drugs we can stop the seizure if the seizures last for more than 150 seconds. So the main optimal duration of seizure should be more than 25 seconds, but it should be less than 120 seconds. Okay. So how frequently we can use this current? Any idea? Yeah, I'll tell you, because we can do this 3 times a week for 6 to 12 treatments. Okay, 6 to 12 treatments. It could be of 3 times a week. Then followed by weekly or monthly as a maintenance therapy. For a treatment purpose, it should be 6 to 12 treatments only we have to do. But for maintenance purpose, you can maintain up to initially as a weekly, then as monthly ones. Like that we can do. Okay. Then maximum you can done till the improvement is seen, or if treatment is deemed unsuccessful. Okay. So the main thing, you have to place before that in the ECT you have to keep the setting, then place the electrode, then apply current, then look for the seizures, generally tonic-clonic seizures. Then 3 phases you have to see, then you have to observe the seizures. How long it should be last? It should be more than 20 seconds, 25 seconds, but it should be less than 120 seconds. Suppose if the seizures is prolonged for more than 150 seconds, then what you have to do? You should terminate the seizures by giving the drugs like injection diazepam 5 milligram. Or if it is not subside, then what you have to give? Then you have to give thiopentone or phenytoin. Okay. Then the treatment should be last for 3 times a week for 6 to 12 treatments, followed by a week or weekly or monthly till the maintenance therapy. Usually it has to be done till the improvement is noted. Okay. As I told, we are keeping the electrodes unilaterally and bilaterally. So most commonly used is bilateral. That is temporoparietal is we are using. Bilateral ECT is more commonly preferred than unilateral. Where we are keeping the unilateral electrode, it is in non-dominant hemisphere. Okay, unilateral is not usually preferred when compared to bilateral. Okay, it has a main advantage of bilateral is it has an advantage of reducing the cognitive effect, and it has only fewer side effects when compared to the unilateral, because in unilateral, in non-dominant hemisphere, both the current is produced, we are sending it into the unilateral side, so lot of current we are pushing it into an unilateral side, whereas bilaterally we are equally dividing the current. Okay, so we can have lesser side effect in the bilateral ECG when compared to the unilateral ECG. Okay. Then now we have seen what are all the steps we are doing. Then what is the observation? What is the physiological changes? Main thing in cardiovascular system is initially there is an parasympathetic activity. Parasympathetic activity usually lasts for 10 to 15 seconds. What are all the parasympathetic activity? What the patient will show? They will have bradycardia or hypotension. Usually it will subside, but sometimes rarely it go to asystole, or sometimes premature atrial or ventricular complex, ventricular tachycardia. Then these are all the parasympathetic activities. Then later what will happen? Initial parasympathetic, later there will be sustained increase in sympathetic activity. Okay, in sympathetic activity, what will happen? There will be an increase in heart rate, increase in BP. So increase in heart rate is what? Tachycardia. How will you say it is tachycardia? When there is more than or equal to increase in 20% from the baseline of heart rate, more than increase in 20%. Whereas systolic hypertension means more than 30 to 40% increase in systolic BP, and also increase in myocardial oxygen consumption. So because of this increase in myocardial oxygen consumption, so there will be an reduced myocardial oxygen supply because of tachycardia. Okay. So then oxygen demand supply will be imbalanced. Oxygen demand is increased, but the supply is decreased. So there is an imbalance between an oxygen demand and supply. So because of that, there will be worsening of myocardial infarction. Okay. Patients who are vulnerable for this, they will have still further prone to develop myocardial infarction. Then patient who had left ventricular systolic and diastolic dysfunction and cardiac arrhythmia, sinus tachycardia, PVCs, paroxysmal ventricular, and bigemnies, trigemnies, and ventricular tachycardias, VPCs. Okay. So many VPCs can occur, or bigemny, or trigemny, or ventricular tachycardia. Then few of the ECG changes. What you will note, if there is any MI, what ECG changes, either ST depression or D wave inversion. Sometimes there won't be any change in the myocardial enzyme levels, but ECG changes will be there. These are all transient only. But if for that only we have to select the patient. Criteria should be important to select the patient. If a patient is not fit to undergo this ECT, we should not take. For example, MI patient we should not take. Recent MI for less than 3 months now we should not take, because if we are handling this patient to go for reduced myocardial oxygen supply now, then further worsening. So better avoid. That's why they are comes under absolute and relative contraindication. Okay. So this is the cardiac changes. Moving on to the central nervous system. There will be increase in cerebral metabolic ratio oxygen. Okay. Cerebral metabolic oxygen demand is also increased, and cerebral blood flow is also increased. It is 1.5 to 7 times increase from the baseline, and increase intracranial pressure and cerebral vasoconstriction initially, which is later increase in chance of cerebral hypoxic event. Then moving on to the other changes like increase in intraocular pressure, increase in intragastric pressure, and there will be a reflex esophagitis. These are all the physiological changes you will note. Main cardiac is initially there will be parasympathetic followed by sustained increase in sympathetic activity. Parasympathetic means, as you know, it is there will be bradycardia and hypotension. Whereas sympathetic, it is exactly opposite. There will be tachycardia and hypertension. So because of this tachycardia and hypertension, myocardial oxygen demand supply will be altered. So patient will be prone for MI or arrhythmia. Already having some conduction abnormality, now patient will go for arrhythmias. Then heart block. These are all the cardiac effect. Then CNS la increase metabolic oxygen demand, increase cerebral blood flow, increase in intracranial pressure, increase in intraocular pressure, intragastric pressure is also increased, and reflex esophagitis can occur. Okay, these are all the physiological changes you will note. Then moving on to the complications. If you are giving an ECT, what are all the likely neurological complications you can expect is they will have short-term memory loss, and they will have headache, and patient will have cerebrovascular accident. How it will happen for cerebrovascular accident? As I mentioned earlier, if already patient having some intracranial mass, if you didn't note, then happen to go for ECT now, then due to that sympathetic action, increase intraocular and intravascular pressure, patient will go for cerebrovascular or CNS accident will have. Okay. So better, most important thing, optimize the patient and take. Indicated patient, take. Otherwise, treat them with medical management. Okay. Then other neurological complication is status epilepticus. Then emergence agitation. Patient will be drowsy, confused, disoriented, and attention deficit can also occur. Then cardiovascular complication is MI, congestive cardiac failure, and sudden death, maybe due to asystole or due to this congestive cardiac failure. And suppose if the emboli, thrombus emboli dislodged to the pulmonary artery, now what will happen? Pulmonary edema, obstruction edema. Then transient arrhythmias can occur in case of conduction abnormality. Due to this tonic and clonic contractions, patient will feel myalgia and they will have weakness in their body. And patient will have nausea, vomiting, and they will have anorexic. Fractures and dislocations can occur. And patient will have amenorrhea and pulmonary aspiration. If patient, suppose if you have taken a full stomach patient or already you had a GERD, they may likely to undergo pulmonary aspiration. So there is eternal vigilance is more important. Then moving on to the anesthetic goals. Rapid and smooth induction is more important. Analgesia, amnesia, muscle relaxant, airway protection, and control of hemodynamics, prevention of complications and bodily injuries, and it should be a rapid and smooth emergence. These are all the anesthetic goals, which patient should have smooth induction and smooth emergence. Okay, and adequate what? Airway protection and muscle relaxant and control of hemodynamics is needed, and we should prevent the complications and bodily injury. Okay, these are all the anesthetic goals. And main anesthetic consideration is we should take a proper history and what are all the drugs they are taking and look for any drug interaction. And it is a shorter duration of procedure, so we should have eternal vigilance and monitoring is more important. And we should have an anti-aspiration prophylaxis, hemodynamic alteration. We should treat and use the anesthetic drug which does not alter the seizure activity, and we should look for the complications. Excuse me. And moving on to the preoperative evaluation. As I told, history is and examination is more important. We should look for any difficulties because in history taking already the patient is in mentally ill. You won't get a reliable history. Usually it is an unreliable history. So we should have a bystander nearby so that we have a proper history. Then we should look for any coexisting disease, CNS, CVS disease, and any osteoporosis and any fragile bone is there or not. Then we should look for any contraindications for ECT. Consider any other cardiac and respiratory and musculoskeletal disease. And we should look what are all the medications they are taking. And we should do the proper routine blood investigations. Then you should check the ECG and chest X-ray and renal function test, because whatever drug we are giving during ECT has to be eliminated via the renal to prevent the cumulative effect. So they should have a proper renal function. Then moving on to the preoperative drug administration. So already if the patient is continuing few drugs, now they should, whether we should continue the antipsychotic drug or we have to stop, we should know it. Okay, otherwise patient will land up in severe problem. Okay, suppose if the patient is on monoamine oxidase inhibitor, suppose if the patient is on moclobemide, we should stop 24 hours preoperatively. Whereas isogorbic acid and all, isogorbic acid and all, we should stop 2 weeks before the surgery. And selegiline, it is not necessary to stop if the dose is less than 10 milligram per kg. Okay. Then these are the some of the drugs they will be commonly used. SSRI, they should be continued with the ECT. Whereas TCAs, tricyclic antidepressant, it is that drug also should be continued during ECT. But lithium, it should be discontinued because of its prolonged duration of action of muscle relaxant, and it has a bad interaction with benzodiazepine. It will prolong the duration of action. So better you should stop the lithium 24 hours before the procedure. Whereas monoamine oxidase, few you can continue and few you can stop. Otherwise, hypertension and sympathetic action, already patient will have later times it will have sympathetic action. So already patient is on monoamine oxidase, they'll have an interaction. So better you continue. Okay. Then moving on to the pre-medication. In the pre-medication, NPO, that is nil per mouth, is a more important one. Suppose if the patient has had any meals 1 hour or 2 hours before the procedure, then they are likely to aspirate. So nil per oral we should keep for 6 to 8 hours for solid foods. Okay. Then we should get a consent. Consent should not be, usually won't be valid if the patient is mentally insane. So for that valid consent, we should get it from the parents. Okay. First degree relatives. Okay. Then we have to give glycopyrrolate. It is an antipsychotic and it's a parasympatholitic drugs. Okay, parasympatholitic drugs. Its dose should be 0.01 milligram per kg IV. Then atropine usually is not indicated as it causes severe tachycardia. Severe tachycardia, already if it is sympathetic drive is more, then you are giving atropine, then patient is likely to go for arrhythmias. So better to avoid atropine. So you can use glycopyrrolate. It has a parasympathetic action and it has an antipsychotic activity. Sedatives is to be avoided as they have delayed emergence and they also have the increasing seizure threshold. Okay. Then moving on to the anti-aspiration prophylaxis, because if the patient is aspirated now, then it will go for aspiration pneumonitis. So you have to give the prophylaxis like 0.3 molar sodium citrate 15 ml or H2 antagonist ranitidine 1 milligram per kg IV should be given, or metoclopramide 10 milligram IV should be given. Then we should blunt the sympathetic response, which is usually it is not used. Okay. Suppose if you are using the sympathetic response blunting agent, now what drug? We can give atenolol 25 to 50 milligram per oral, or sublingual nifedipine 10 milligram we can use. Then what are all the OT preparation needed? OT preparation, what we will need, we should have a field assistant. Then drugs, we should keep ready with beta blockers. For, as I told, no beta blocker, labetalol, esmolol, or sublingual nifedipine, these drugs we should be kept ready. Suppose if there is any sympathetic emergence, now we can use this drug. Or IV nicardipine, or IV NTG or hydralazine can be used. Then airway equipments like ambu bag, airways, face mask should be kept ready. Suppose if there is any difficult airway, if you want the patient to be intubated, these things has to be kept ready. Even though it is a minor procedure, we can land up any patient to go for difficult airway. So better we can keep it ready. Then laryngoscope, endotracheal tube, stillet, bougie, laryngeal mask airway, and defibrillator, suction, everything should be kept ready in the operation theater. Okay. Then once you kept ready, well, then you should look for the induction agent. What are the induction agent? The gold standard drug is methotrexate because it has an minimal anticonvulsant effect. It doses 0.75 to 1 milligram per kg. Then following that, afterwards, etomidate they have developed. Etomidate, its dose is 0.1 to 3 milligram per kg because of its reduced seizure threshold and prolonged seizure duration action. Okay. The main disadvantage here is patient will have post-operative nausea, vomiting, and they will have longer emergence time, and they will have increase in muscle tone, and they will have pain on injection. So etomidate, they are not using that much. But if you are using propofol, even though they are having pain on injection, but these people had an advantage over the etomidate is they have better cardiac stability and with a reduced post-operative nausea, vomiting and faster emergence is as good as methotrexate is propofol. Okay, its dose is 0.75 milligram per kg body weight. Okay, but most commonly used is thiopentone. Its dose is 2 to 5 milligram per kg. Main advantages is as longer duration of action when compared to propofol. But here main disadvantages, it has reduced cardiovascular stability and causes rise in intracranial pressure, and it has an emergence agitation will be there. Then one of the drug which is not used because ketamine is not used, it causes severe adverse cardiac action. It will increase the heart rate and BP. So better avoid ketamine. Don't keep ketamine for induction agent in ECT. Okay, you can keep thiopentone or propofol, etomidate, methotrexate. Okay. Then moving on to the muscle relaxant. Most preferably used is succinylcholine. For induction, for muscle relaxant, succinylcholine, for putting endotracheal tube, we will use 1 to 2 milligram per kg body weight. But for endotracheal, for ECT, we are using 0.5. That is half dose. 1/3 of the dose is used. Milligram per kg body weight. 0.5 milligram per kg body weight is used. The main drawback here is there is a minimal increase in intracranial pressure and intraocular pressure and intragastric pressure. But this is the drug of choice. If you are using mevacurium, it needs a reversal. Okay, neostigmine is needed. Whereas if you are using succinylcholine, it is eliminated by plasma cholinesterase. If you are using mevacurium, you have to give one more additional drug for reversal. This neostigmine. So better use succinylcholine. This is the drug of choice. If you are using mevacurium, its dose is 0.15 milligram per kg body weight, but it needs a reversal agent. Okay. Then what are all the other drugs we are using is remifentanil. It is used in patient in whom seizures are difficult to elicit. Okay, in few cases, after giving electrical stimuli, there is no seizure activity. So for that, in that case, we can use remifentanil. And also in few cases to prevent seizure and to reduce the dose of induction agent and increase the seizure duration. And one more drug is caffeine or theophylline. It has the reduced seizure threshold but prolongs the seizure activity and used for seizure augmentation. Okay. Then what is the procedure? What we are using is in few cases ET tube, endotracheal tube, if necessary, only we will use. Otherwise, only mask ventilation is enough. Where endotracheal tube is necessary is those patients who are all risk of aspiration, like a pregnant patient, GERD patient, or hiatus hernia patient. These patients are having more chance of having aspiration. So for them, better to intubate. Okay. And some anesthetists, they will induce the neuromuscular blocking agent. Okay. Some anesthesia is induced with neuromuscular blocking agent. And if the patient is ventilated with oral airway and ambu bag, then you should give 100% oxygen. Sometimes you can use LMA to protect the airway. Moderate hyperventilation is beneficial to improve the quality and duration of seizure. Then once the current is passed, then seizure will be elicited. Before current passing, once the patient is under, you should keep one bite block to insert it to protect the airway, because the patient develops seizure, they will clench the teeth. To protect the teeth, you should keep the bite block. Then stimulus is applied through the 2 electrodes placed on the patient's scalp. Then after giving seizure, then you should look for the current, then you should look for the seizures. Usually it should last for 25 to 120 seconds. If it lasts for more than 152 or 180 seconds, you should terminate the seizure by giving diazepam, 5 milligram IV should be given. Suppose if the patient complains of myalgia in the post-operative period, you have to give ketorolac, 15 to 30 milligram IV. If the ketorolac is contraindicated now, then you have to use aspirin or paracetamol. In few cases, to reduce the hypertensive response, we can use labetalol, 0.3 milligram per kg, or esmolol, 1 milligram per kg we can use. In few cases, as an alternate to labetalol and esmolol, you can use SNP, sodium nitroprusside, or hydralazine. Sometimes calcium channel blocker like nifedipine, nicardipine, and diltiazem can also reduce the hypertension. In few cases, we can use alpha-2 agonist. For example, clonidine and dexmedetomidine. 1 microgram per kg over 10 minutes should be given before induction to reduce the hypertension without affecting the seizure duration. Okay, so these are all the drugs to optimize the patient. Okay, like sodium nitroprusside, hydralazine, calcium channel blocker, alpha-2 agonist. Okay, and what are all the monitors? Monitors like ECG, non-invasive BP, pulse oximeter should be attached to the patient, and we should observe for visual observation for of the limb. For what? For we are visually observing the limb to see the seizure. Okay, and how long it is coming. So we should note the duration of seizure by visual observation of the limb. And the seizure can be central and peripheral. Centrally, we can observe the seizure by EEG, whereas peripherally we can observe by EMG, electromyography and electroencephalography. Okay. Then post-ictal care, what are all the care you should give? You should supplement oxygen till the patient is awake, and they can hold the airway, protect the airway. Till the time you should supplement the oxygen. Then midazolam 0.05 milligram per kg IV to reduce the emergence agitation. Then you should record the anesthetics and neuromuscular blocking agent. As the treatment is not last for a single day, it will last for over a week till the patient is required. So better properly observe, record everything so that this is followed and for the further treatment purpose. Okay. Then what are the complication is expected is post-ictal confusion, then agitation. Sometimes patient will be aggressive. To treat them, you have to give midazolam. If the patient had headache, treat them with NSAIDs. Then they will have the reversible memory loss and cognitive impairment. This reversible memory loss is useful. As I told, if any brain damage occurs, then the patient will have the memory loss. Then they will feel, once the memory loss is occurred, then they will feel they have come out from the illness. So this is betterment for the patient. Then treat, if patient is having nausea, vomiting, treat the cause. Then you should look for any fractures and dislocation. Then oral and dental care should be given. Then avoid the laryngospasm and any exacerbation of ischemic heart disease. Okay. Then before concluding, as a summary, so what is ECT, you know, and who found it out? ECT is nothing but giving an electrical current temporarily, then we are altering the brain electrical activity and producing the seizure, and the seizure should last for 25 to 120 seconds, so that patient will develop a transient change in the brain and they will have memory loss and some difference in the cognition. Then patient will feel they have cured. By repeating this sequence, patient will be subsequently improved. So in that we are using what drug? So induction agent is methotrexate is the drug of choice, but propofol also play an important role, and thiopentone. Thiopentone of dose of 5 to 7 milligram per kg is being used. Then after induction, we have to give what drug? Muscle relaxant. 1/3 of the muscle relaxant. Better to use succinylcholine, because succinylcholine doesn't need an reversal agent to reverse. Okay. Then we should know what are all the likely complication patient going to happen and how to treat them. And selecting the patient is more important. And if the patient is not fit for, don't take, because alternative treatment is medical management is there. Better you can treat the underlying cause, underlying medical illness, comorbidities, then you can take them for ECT. Okay. Thank you.